on. It's January 30th, Thursday, and we're going to spend some time with corrections folks to talk about how our current MOUD or MAT, the old name, is carried out within our correctional facilities. And we have two folks here who have been here before, so welcome back. And I'm not even going to try to pronounce your names. We've got the Executive Director of Health, Wellness, and Engagement for DOC. And we also have the Medical Director for WellPath. And I'm assuming both of you want to come up at the same time.
And Chair, we also have on the line Travis Denton, the Facilities Director.
Okay.
Speaking of the facility side for the justice.
Well, that's a good thing. You didn't scare you away the first.
I don't know, I'm sure I feel lovely people.
So I know we've had some preliminary conversations about MOUD within our facilities, but I think I'd really like to talk about how it's administered within our facilities. And really have an open conversation with the committee and you folks to get a better understanding of how it's administered, what are positive, what's positive about it. And I'm sure there's some negative to that. And I think we also need to hear that. And I don't know if DOC has some thoughts or new initiatives that they wanted to try to put on the table for
High
MOUD.
level.
High level. Because we also have H32 here that we're going to take some more testimony on next week with our legislative council to walk us through the proposed legislation. So we do want DOC in the room for that. And I don't know where H32 is going to go. I don't know where any of this is going to go at this point with MOUD, but I want the committee to really have a background in terms of how it's administered within the facilities. So I'll turn it over to both of you if you just identify yourselves for the record. And you go from there.
I'm Dr. Jim Uliger. I'm the State Medical Director for the WellPath.
Thanks for having us back. Aviva Teba, I'm the Executive Director of Health, Wellness, and Engagement for DOC.
I guess we had planned a bit of and I'm happy to directly address your question of how is this administered. And I think looking a little bit over time, because there's people in this room that were here when this was started and when we began. So MOUD began by law in Vermont correctional facilities in 2018. And that was a big undertaking. And there's, like I said, there's people in this room that can speak more to it than I can. I want to honor that undertaking because I'm going to talk about some of the changes. So I've been the medical director, said last time, since June, but I started last January as the addiction specialist for WellPath. And when I came in, there were a lot of changes we need to make to modernize, for lack of a better word, the administration of MOUD within the correction system. But I don't want to talk about the need to modernize without, it sounds like I'm not doing justice to the people that came before. And I actually want to do the opposite. It was quite an undertaking just to get something in. So yes, we got there. And then some things we had to do. So when it was begun, there was a mandate to start who needs this and let's get them all medicine. It was a little bit of a challenge.
It was interpreted a little different than what the legislative intent was.
Got it. And I believe that. And again, I was not part of that.
Yeah.
It's a little bit, and if you look at kind of the machinery that we've set up, it's a little bit intended to finding who are the people within our facility who need this. For the most part, we start people now when they come in. So,
but is that after an assessment? You must screen.
Absolutely.
I think the committee members need to hear that.
Yeah,
when someone comes in, they're arrested, they come in, they're going through booking. What happens within the MOUD world?
Yes. So there's roughly 3 different ways that you get involved in our MOUD program. One of them is that you're already on MOUD in the community, and we continue.
But they voluntarily give you that information, don't they? Or not?
Well, so usually we say, are you on MOUD in the community? But we also do medication verification so that we're looking at the Vermont prescription monitoring system. So we know often when, or they're withdrawing. And often when we see somebody in the facilities because they were on MOUD and went off of it and something bad happened. So now they're in our facility. And so we're trying to figure out, well, what was the thing that happened? And we see by Vermont prescription monitoring system that they were in fact on MOUD. One of the big changes that has been made in the last year, and I don't want to, it's not just me, it's a lot of us, is that, well, if you missed a dose or you missed 3 doses, or if you missed 2 weeks, yeah, we don't consider you as continuation. We totally consider that a continuation because continuation is the easiest way to get somebody back on, I should say. So if you're on buprenorphine, you had a return to use, and it's been 3 weeks, and we find you, we say, oh yes, you are on whatever it is, 16 milligrams of buprenorphine in the community. There's had it last time as saying, well, no, you really weren't on it. So we've changed that. So that's way number 1, we get people on. Way number 2 is you either are not on MOUD in the community or you've been on it distantly, but you come in and you're clearly in opiate withdrawal, or you go into opiate withdrawal within a couple of days. We have a system of it's called COWS. We assess how bad your withdrawal is. You cannot start buprenorphine right away when somebody has just had a use because you'll make them sick. You'll put them into withdrawal. So we wait for a certain amount of time until it's appropriate, and then we start medications for opiate use disorder, buprenorphine. And we go through an assessment. There's a diagnostic. So everybody gets screened when they first come in. We ask them. They get a formal, it's called the Texas Christian University, the TCU screener. Yeah, the TCU screen. And then it's actually for all opiate or for all substances, but then there's an opiate specific addendum. To be honest with you, even though everybody is screened within the first few hours of being in there, it's very common people say no.
No to what?
A note, they say they do not use substances because you're in booking and security is right over there. And we do our best about privacy and everything, but, and maybe you're still under the influence of a substance, whatever. So it's very common people will not admit to using substances, but within several hours to a day or two, it becomes clear that they're in opiate withdrawal. So what we do at that time is we approach them and say, and usually this is one of our, we call them our MAC case managers, so our case managers for opiate use disorder who have more training than the intake person who is a general nurse or LNA who's doing this. These are people who have specific addiction training. You know, it looks like you're in withdrawal. We'd like to measure that and put you on, consider some medication for opiate use disorder. One thing that for years, we have always, in addition to making that assessment, we give them medicines for their comfort. We give them ibuprofen, some Gatorade, because usually they're severe muscle aches, sweating, vomiting, diarrhea. So we treat those symptoms. The U.S. Department of Justice has made the mandate that we should be treating those symptoms of opiate withdrawal with buprenorphine. So, and I'll make this a little clearer in a second, but I'll tell you, almost nobody across the country is doing it. We've put in some systems in place in the last year where we're about to be able to start doing that more aggressively. And so the idea is, to use buprenorphine, and I'm going to use specifically buprenorphine because that's one, if people are on methadone already from the community, that dosing is going through their hub in the community. Because we're not an opiate treatment program, you have to be an opiate treatment program to provide that. So we're using buprenorphine. It's only FDA approved for treatment of opiate use disorder in that dosage form. There's other forms that are for pain and whatnot, but in that form, you have to have opiate use disorder. Sir?
I just need a clarification on that. So DOJ's recommendation is to treat the symptoms of withdrawal with
With agonist treatment.
regardless of whether or not those symptoms have been confirmed as withdrawal.
So it's usually pretty clear that they're from withdrawal.
Okay.
The question is, are you withdrawing from opiates? Question one. Question two is, can we diagnose you with opiate use disorder? Okay, two related but separate questions. Having withdrawal is diagnostic of dependence, but not opiate use disorder. Okay. And so here's what we did with our policy. So we can start, the DEA now allows us to begin buprenorphine to treat opiate withdrawal in advance of a more thorough evaluation to diagnose somebody with opiate use disorder. So it's medicine first, then more thorough evaluation, enough evaluation to know that you need meds, right?
But you don't want to start it too soon if they're going through withdrawal because of the after side
Exactly.
effects.
Yes,
Let me
exactly.
just follow up on that, and I don't necessarily want an answer now, but it's a good place to put a pin in this. I'm gonna want to talk about the guidelines that are in place for not introducing folks to MOUD who don't need it.
Absolutely.
Yeah.
So, but no, I was actually just about to talk about that, if that's okay. So people, if you're an opiate withdrawal, we can put you're already on, your body's dependent on opiates, and that means you're dependent on opiates to stay out of withdrawal. So we can start you on buprenorphine and taper, and if you are found not to have an opiate use disorder, then we taper the buprenorphine, and then you go off it. To be quite honest with you, it's very uncommon that people are in withdrawal in the current situation and do not actually have an opiate disorder. There's a few ones that I really do want to talk about. But the goal is, and this is very, you when I was new to corrections, I am new to corrections, but I was really new to corrections. You see somebody on the floor in a concrete cell, diarrhea and vomiting and sweating. It's a terrible thing. And we can give them all the anti-nausea medicines and ibuprofen and all that, but it's still awful. So it's much more humane to treat them with buprenorphine, taper if it's appropriate, and then go on from there. And it's really important, and I've stressed this to my medical staff over and over again, we have to use the DSM criteria for opiate use disorder. We're treating some of the wrong people. And if we're treating some of the wrong people, then they're leaving corrections at the end with a dependence and possibly addiction to a substance they didn't come in on. We're trying to avoid that.
Mhm.
So some of the ways we're doing that, so we re-administer the TCU. I'm really doing a lot of education with our clinicians on when somebody comes to you. I actually, right before I came here, I was having a one-on-one with one of our providers, and she had turned 2 people down for medications for MOUD, and she didn't feel good about it. And like, well, why did the person want treatment? It's like, well, they just really are feeling down in prison and they feel like they need something to cope and they're having pain. I'm like, oh my gosh, okay, wrong person, wrong indication. By law, we are not allowed to use this medicine. Most people in the facility are feeling down. What did you do? She's like, well, I connected them with mental health. Yes, yes, that is the right thing. Another thing we're about to do, and I apologize, I might have mentioned this last time, but and this was not my idea. It was one of my our lead nurse practitioner for MAT services. So, I really think we need to start aggressively treating alcohol cravings, which we do have medication for. And because people are saying it's no big deal, and here when I'm not with my people and places and things, I'll be able to go without alcohol. But then they get in the yard and they're having a hard time, and somebody says, hey, how about a little bupe? Because it is diverted, and that's another thing that we're addressing, and I'll talk about that in a second. So she's like, we need to be aggressively treating alcohol cravings with Vivitrol to decrease the risk that people who have alcohol use disorder are going to be seeking other things. The other substance that we see people having generalized cravings for is cocaine. Less methamphetamine here than I worked in the South for a while, loads of methamphetamine. We don't see it that much. Methamphetamine is the most addictive substance we have because of how it works on dopamine. Not a lot in Vermont, thank goodness, although, it'll be here. But cocaine, you'll see people on cocaine and they'll have cravings, and there we are. That's a challenge to kind of address those folks. So there is within So the DEA allows you to get buprenorphine started based on some initial symptoms, and then within 3 days, we do a diagnostic interview. So I don't want to give the impression that we're doing that well yet. We do get people started. The reason for that 3 days is that in some of our very smallest facilities, we don't have a provider there every day. I would like to have, and we're working on having a provider there every day. Or maybe it's a holiday, or maybe there's different reasons why it might be difficult to get people a diagnostic interview that day. And then a higher volume setting, we can only see so many people. Also, when people don't feel horrible, you're able to have a more therapeutic conversation with them. What really was it that you were taking? When, it's hard when somebody's vomiting and sweating and feeling terrible. So we're big on the diagnostic piece, and we need to get better. So we have new guidelines for dose titration. One of the things I saw when we came in is we put people on, and we talked about this last time. Really, if you're on fentanyl on the streets, you need to get to 16 milligrams. And then you might even need more. But to feel better, you need to get up to 16 milligrams of buprenorphine. There were older guidelines. When I was trained in buprenorphine in 2015-ish, we were giving 2 milligrams and we'd wait for a while. We'd give 2 more. Our new protocols, you get 8 milligrams. If you still feel sick tomorrow, you get 12 milligrams. And if you still feel sick the next day, you get 16 milligrams. Done. And yes.
We have questions.
Yes.
I think he's partly answering, you said we need to do better. So are you explaining that in your next statements?
Yeah, sure. Of treating withdrawal with agonist treatment that we need to do better, that specific thing. Right. So, yes, we need to put that in play. We need the systems to put that in play, because what does that mean? So that means that a nurse in the facility on a Sunday might need to reach out when a person gets to a certain level of withdrawal to a provider on that Sunday who needs to have the comfort to start that medicine over the phone on the weekend. And then to be DEA compliant, we need a mechanism to make sure that within 72 hours, the person has diagnostic interview. So those are some things, and it sounds it's never as easy as it sounds. But I don't know there's like 1 or 2 or 3, when I look nationally, there's very few people actually doing that. And that's our goal. I didn't bring it because it's 15 pages long, and I showed it to these guys. They're like, let's give a summary. So I'm giving a summary. But in our new policies and procedures that we're just rolling out, there is basically a pathway that there's a diagram that says, how do people get into treatment? And basically at the center of the pathway is the diagnostic interview. And there's all of the feeder lines that I was just talking about. So you see, if you get this, if you get started before you're fully diagnosed, that we get you to that diagnostic interview. And so we are getting people started pretty quickly, but we're not quite up to that point right? There's still some people with anti-nausea medicines in the Gatorade bottle. And what are we doing? Can we get that person on? That's the right thing to do.
We have another question, Gina?
What would you say, I don't know if you have the numbers or percentage of folks that come in that aren't in withdrawal, that are started on a course of buprenorphine in the facility because they meet the criteria for opioid use disorder, or they're telling you that they meet the criteria for opioid use disorder because they're in prison and it's an environment where there's a lot of time and the need want for that when everybody else has got it is to be there.
And that's absolutely a thing. It is possible that some people have gone through some withdrawal and it wasn't captured in whatever way when they come in, they were using before they came in. And then months later they say, or maybe we offered it to them and they said, no, I don't want MAT. And then 6 months later, they're like, I actually think this would be a good idea. That's I don't have a number for you. It's much less common. We do also get people saying, look, I've been buying this in the yard. I would like to start this now. And that's where our diagnostics come into play, because is it too much detail? There's there's a dozen criteria, but there's 4 main criteria. Physiologic dependence, so you get sick when you stop taking it, number 1. Dangerous use, so you use it and then drive. use despite negative social consequences. So you, your family asks you to stop using it, and I'm going to leave you if you keep using it too. Why am I forgetting fourth? Dangerous use, dangerous use, social consequences. I'm forgetting fourth. I'll remember. But we need those. Persistent loss of control. So you try and stuff. You're like, actually, I don't want this in my life anymore, but it's still in your life because it can't be. So people would come to me, and I'm getting this question much less often now. So hopefully it's coming home. People say, well, I had to start this person because they said they had opiate use disorder, and we tested their urine and there's bupe in it that they've been buying. So they have opiate use disorder. No, that's not the criteria. Their criteria, what's their TCU score? I didn't do the TCU. Yes, we're doing the TCU because we want to do that diagnostic criteria. So poor judgment is part of a substance use disorder, but it doesn't itself make an opiate for substance use disorder.
So you really have to work with your staff to make sure they can see those little delineations and take that's the key, I think, in terms of whether or not someone is on the MOUD or how you manage that.
Yes, and it's a very nuanced. And so I was a little bit unpopular in certain times and places in the last year because I was insisting people think very critically, and there wasn't a wet and dry answer or a clear-cut answer.
Simple question. What are they buying in the yard? Opioids?
It's
Diverted.
buying diverted
It's
bupe.
diverted bupe.
What's diverted? bupe?
Oh yeah, so
Can hide it.
they're hiding it in a crevice in their tooth.
They're on MAT or
MAT.
MOUD.
Or somebody is.
They
But they're
haven't,
not using it.
they're not, they're hiding it and then
Yeah.
it's contraband with
So
the
when
facility.
they have them show under their tongue, they have it somewhere that
Yeah.
they can hide it.
Okay, I just,
Yeah.
some clarity.
It's used,
Oh, no, that's a very important thing.
it's very important.
So we are going to see some level of diversion. This might be a good time to talk about things we're doing, the response to diversion, because the response to diversion in the past has always been you get a warning, then we cut your dose in half, and then you get taken off of it.
So maybe you could explain, and maybe you're not the person, maybe it's Isaac or someone. The culture within a correctional facility, inmate to inmate, there is a power hierarchy, power struggle, and diversion is part of that. And I don't know if you could expand on that, kind of explain a little bit better. There could be somebody knows something about somebody and it's like, well, if you pay me for some bupe, I'll keep quiet about it. You know, there's a lot of
There's coercions,
coercion.
there's have and have nots. There are things diverted within the facility that would, I don't want to say never be diverted in the community, but it's just not received. Wellbutrin. Wellbutrin is an antidepressant that has a very modest stimulant effect. That is diverted in the facility. Gabapentin, neurologic pain agent is diverted. It's amazing. So it's just the idea of scarcity and power dynamics. I think those that scarcity plus power dynamics.
And you can't give this as an injection. Sorry.
Well, we're getting there. You're ahead of your skis.
Oh, sorry. Okay, I'll pull back.
Oh, it's a question. Like, let's go right there. It's extraordinarily expensive.
10-4. Yeah.
Yes.
But
And boy, that would be great. I did that. So it's depending on which formulation you do, it's a weekly or monthly injection or whatever. And I did the calculation when I first started, like we could get rid of all the med lines, like no med. We took the salary of the corrections officer, the nurses passing the meds, all the things, and it paid for like 2 doses or something. Just so yeah, I tried to make it make financial sense.
Troy,
You just flagged something for me, long lines.
long lines, yeah.
One of the things I have heard from coming out of CRCF, the women's facility, is that administration of this medication begins at 3 a.m. So you're waking people up. Is that accurate?
I thought it was 4, but I don't know why. I mean, is that something you can speak of? I don't know why it's happening.
No, I think it's just difficult to fit everything in. A lot of people take a lot of medications and it takes a lot of time the way we currently administer other medications and MAT.
So do you think 3 a.m. is accurate?
That I cannot specifically speak to, although Travis may be able to if he's here
Yeah, I think Travis is on the
virtually,
line.
the facilities director.
At CRCF?
No.
I heard the
POC.
specific to
Yeah,
CRCF.
but we can look into it and see if it's left.
Yeah, it might be helpful for the committee to understand how the line works, how it is administered and where in the facility it's administered, who's involved, how much time it takes.
Yeah,
And that's not like going to their cell and handing it to them. That's getting them up, going to at 3 a.m. Let's use 3 a.m. because that's what I heard. But that's getting them up out of their cell to the
Yeah.
infirmary, yeah.
yes. And I think the answer to fix that is our proposal to normalize Medline. Before we get into the normalization of Medline, maybe there seems to be a question of what does Medline look like now?
Yes.
Okay. Buprenorphine and methadone are given at a separate Medline.
And the med line is to the infirmary.
It might be in the infirmary or it's in some space. It's
Who is there in terms of medical and correctional officers?
there is a nurse who's passing the medication, and there's a corrections officer or two, and it might be one, it might be two, it depends. People get and I'm going to speak to the generality of the process. One of my colleagues who's on the front line could speak to the very specifics of exactly what happens. People get them out. The nurse reads your name. Are you so-and-so? They're supposed to check your wristband. They say, does this look like your dose? You get a mouth check. Is your mouth empty? You get the medicine put under your tongue. You go sit on your hands for 10 or 15 minutes. You're not supposed to say anything, do anything. When they put the medicine under your tongue, the corrections officer looks to make sure it's there. Before you leave, after a set amount of time, they check under your tongue again and make sure it's not there. It's a long process. So if you have 20 chairs and you have to sit 10 and 15 minutes at a time, and you have at Northern State, I think close to 200, I don't know what the exact number is, well over 100 people on buprenorphine plus methadone. It takes a long time. If you have methadone, you're supposed to say your name and eat a cracker or something like that, because it's liquid. The methadone is liquid. And if you're able to do those things, it's much less likely to get deferred. Though we do see deferred methadone, which is scary, because methadone is, you can overdose on methadone. Very hard to overdose on buprenorphine. So that keeps me up. So it's a very arduous process. It's a big risk for our patients, because anything that they do in that med line that seems like, and the medical term for it is aberrant behavior, because it's not a diversion or anything. That diversion is a specific behavior. Aberrant behavior is that's strange. That's all it means. Like, that was weird, right? So any aberrant behavior by the security folks can be seen depending on how that particular security officer feels about MOUD, and we have quite a spectrum, right? You were talking in line, go back to your cell, you don't get medicine, and then you're getting written up, and then you get written up, and if you get a major, I don't know what DR stands, you know what DR stands for?
A disciplinary report.
Disciplinary report, you get a disciplinary report, and that could affect things like parole, the good time, your privileges in the facility. So there's a risk to coming to Medline that you'll get in trouble, basically.
Depending on who is staffing it at the time.
Depending on who is staffing.
There is a culture issue that really arose from the way it was rolled out. It's been difficult for the correctional officers. It was a real culture change for them, and I don't think that they were brought up to speed in terms of the medically necessary part of this. And I think some of the interpretation from the very beginning is still there. And that creates some issues.
We were the second state after Rhode Island, I believe, to roll this out system-wide, so it's relatively new. And Vermont remains in the minority. Fewer than half of state prisons in the United States offer MOUD, and fewer than a third of jail systems in the country.
One system that went shortly after us was Maine. And Maine has normalized their Medline, meaning they give buprenorphine in the same exact Medline as all the other meds.
Do they do a tablet as well?
They do the film,
You do what?
the films,
No.
the buprenorphine film.
It's like a Listerine strip.
Yeah, it's exactly what it's like. It's a little,
Is that more expensive than the tablets?
it's not nearly as expensive as the injectable, but yes, it's about, I think, I'd have to confirm, but I think it's $10 a dose last time.
And there's less chance for diversion with that? Or
You know-
the same?
So that's the concept. I actually am still trying to figure out if there's actual data to support that. It is divertible. We see diversion of the film in the community, but yes, it is less.
I'm confused as to if an individual needs this to function, what can they get better by diverting the,
Oh, sure.
I guess I'm
Absolutely.
so foreign to this whole system, blowing my
Not
mind.
getting beat up.
Welcome to the world of corrections.
Yeah, I hear you.
So, guys that are picked on in prison look a lot like me, so I'll be the picked on one. So hey, Yulger, you're 5'8" and 160 pounds, and if you go and tell medical 1, 2, and 3, they'll give you this medicine, and then you're going to give it all to me.
Okay.
There's one. Hey, I don't have money to buy shoes, but if I say I'm still sick and I need a higher dose, I could take half of it and then hide the rest in my tooth, because people with opiate use disorder have bad teeth. And then I can get money for shoes by selling the rest. And every iteration of there. So that's a real. Both of those things are real.
So in layman's terms, to avoid being bullied, they give up the meds that help them.
Some people might, or they might not need them in the first place, and they just learned the right things to say.
It's a survival mechanism within a culture.
And that's people are trying to survive, and they're very crafty. And if in my best mind, I can sit there and honor how creative people can be to get their needs met. And that is a real, and this brings us to, so I want to talk a bit about the counseling and the non-medical treatment that we give in the case management, because it's very robust. But that is a tool used by substance use counselors. This is a strength-based approach. Look how resourceful you are. Look how creative you are. But could we put that to a different use? But we do have, I have a few different threads going. We have Medline, we have, I don't know, I would like to talk about all these things, but you tell me. We have a robust case management
Another question,
program.
Gina?
Oh, just to Kevin's point, the half-life of Suboxone is extremely long, so people could be diverting their dose every other day and still not be showing withdrawal signs.
That's true too.
But in that case, wouldn't you be better off giving them a half a dose?
Not necessarily.
And not necessarily, because some people metabolize it a lot quicker and you can't necessarily make that determination.
So yes and yes. So if somebody's really diverting half their dose, so let's talk about diversion for a second. The American Society of Addiction Medicine 2020 guidelines make it very clear the first step to addressing diversion is not cutting their dose, because that makes it harder to stay sober. Diversion is so we're practicing pro-social behavior. That's the whole reason you're on View, is to practice making good decisions. We've made a bad decision. Okay, so the first step is a conversation. What's going on? Why are they? I don't know. My colleagues do. I ask people, is somebody coercing you into doing this? I ask quite out front. Or whatever have you. What's going on? Tell me. You ask 3 questions 3 different ways. You kind of there's a lot of emotional intelligence that goes into it. A lot of bedside manner. It's one of my concerns. I don't fully understand H32. I haven't dug into it. But if we're outsourcing treatment of OUD, these are people that we can sit there, like right there in their facility, being like, come on, man, what's going on right in their face? And we get a lot done that way, right? And so if we're having people seen by telehealth outside, that's a concern of mine. But so there is no one right choice for what to do when somebody's diverting. Some people, here's an easy one. Somebody's only coming to Medline every other day. Man, you have to come every day and you have to get half your dose. Like this is not, or they come when they feel like it, now it's different if it's at 3 a.m. then maybe it's defendable that they're only like, Doc, I'm trying so hard, but that's so early for me. I'm a night owl. Like, yeah, I kind of get that.
Well, as you said the last time you were in, sometimes the answer is no.
And yes,
You know, because it's not as simple as just like the punishment of no, or you don't need it. It might be you need more, I'm not a doctor, so I can't say the right way,
Yes.
but you might need more to regulate you to a point where you can make the better decisions. So it's not just as simple as no, you can't have it, or that you don't need it, that you're diverting.
that's exactly right. So that craving that, so I always tell patients, and I don't, this is most conceptually true, whatever the numbers, right? That the medicine can do 90% of the work. So if you're still having half the cravings you used to, and those cravings are the trigger to do bad things, right? We got to extinguish that craving. Now, we can only extinguish it so much. We can think about 90%. There's 10% of the work. And in some ways, that's a nice thing. Like you still have to do some of it with part of your engagement in your treatment, which is why we offer behavioral as well. But yeah, the answer to extinguish that, 50% of craving that we haven't addressed yet might be to increase the dose. It's a very person specific and circumstance specific.
Another question, Joe?
What is the estimated diversion rate?
Oh,
Is there any, there
great.
must be some data on that.
Yeah, that would be.
It's obviously not 90%, because if that were the case, then you wouldn't have a, program.
Yeah.
There must be some,
We do have that information. I think we
We
presented
track it.
joint justice, at least like percentages and diversion. Yeah.
One thing, you do have frequent offenders around diversion. And
that makes sense.
Yeah.
Anything else?
And so some of those people maybe should be stopped because they're maybe doing it for the wrong reasons. Some of them just might be really sick. So one of the things we're doing, I mentioned our lead MAT nurse practitioner. My goal, once we're staffed better, right? Is to deploy her in a way that she's having the conversations. If somebody's had 6 or 7 diversions in the last month or two, that's not okay, right? And we shouldn't just out of hand stop that person. They might need to be stopped, but they might need something different. So we have her who is a little bit more comfortable with our hardest cases, and she sees them. We might increase their therapy. We might increase their case management. We might drug screen them more often.
So Isaac, you had your hand up, and
Yes.
then we'll go to Gina.
Wanted to really quickly touch base. I think yesterday we heard a little bit of testimony around H13, which we're going to dive into next week. But just really, I think there were some statements around not offering case management. And I think we have to dig into that really carefully, because I know it's something that we've been working on building up in our system. And I'll let Dr. Yiller speak more to that. But we have a lot more information to share on all the wraparound services that are provided to folks with MUD, apart from just the pure medication.
Right, and right now for us, in terms of where H32 is, we just heard from the sponsors yesterday, which is part of the legislative process, and then next week, and you folks will be here as well. We're gonna ask our legislative council person to walk us through the bill, what the language actually says and what it means and how it's linked into statute. And then the committee will start saying, well, if we really want to work on this bill, which I think there is some interest at this point, then we start really scheduling in folks to come in and testify. And there'll be folks who support it, and there'll be folks who don't support it, and there'll be folks who are in the middle and want to present different language and adjust the language. So there is a real legislative process to this.
So
So
set that baseline.
so after our ledge counsel, Katie McLean, is gonna come in next week and walk us through the bill, and DOC, I hope, is in the room, and anyone else who wants to be can be here or YouTube it. And then we'll go from there in terms of what work we do on it.
I appreciate understanding that better. I on behalf of my, and medicine is my comfort place, obviously, so I speak about that aspect, but I do feel a responsibility towards our case management and our behavioral health staff who are experts in their field that come in every day, they sweat and work to make all these things happen. So I just need to make sure, I wouldn't do them justice if I didn't leave today, making sure you guys knew we have and lots of room for improvement. I will, that in the whole contract, that's but they do a great job. They work very hard.
Did you have anything else?
Yeah, how are you linking the diversion to a particular individual?
Oh, they get, so the diversion in this case is really a security term. So this is one of the things as we're looking towards how we might do the med lines differently and whatnot. One of the things, and I could hear Travis talking about it, is what is the connection between when security finds somebody with medicine they're not supposed to have and what medical does about it. So in the past, we've gotten questions like, well, I reported that guy, what'd you do about it? And the answer is none of your business. And at the same time, there's also, we are responsible for the safety of the medicine we're prescribing, right? So that's something I take very seriously. So but the answer to your question is the connection is because it's from a disciplinary thing.
Gotcha.
You said that diversion is really more of the security issue. So do you ever see where a correctional officer will say to that person, because you're diverting, you're not allowed to go back into the med line? Yeah, we've heard that too. And what happens then? Because, you know, MOUD, the goal, it's medically necessary and it's a medical situation. And I understand the security piece, but it's almost like the security piece trumps the medical piece. So how does the medical piece play in here?
So the answer and how and what I can give a very honest answer that how that plays out when I started almost a year ago, or over a year ago, to how it does now is I feel, and maybe it's just time being in here, I've really developed a very good relationship with our security folks. And Travis in particular has sent a very clear message to security staff that there's medical necessity and then there's security necessity. And I am no expert in security. So if you need to do X, Y, and Z, if you say you can't go see that person without an escort, like, yes, you betcha. And I defer to their expertise a lot. And I've come to see it as an expertise. I also think I've developed a lot of trust with, like, look, we really need to, that guy needs to be dosed. And if he doesn't need to be dosed, that's a medical decision. And so when that has happened, it's an education thing.
And has the staff that's supervising the correctional officer, they've been open to that from what you've seen?
Yeah, it's a good, and I think, you know, it varies by facility, it varies by individual. And I feel really good that we have the support coming all the way from the commissioner right down, and that's how it starts. I've been struck at the corrections is a very little bit militaristic, I could say, as a corrections layman. There's a very chain of command, and they follow that. And,
It's different. Also, do you see the delivery of MOU different in the facilities, in different facilities?
yeah, it's different in different places, and it is.
Would be a concern, I would think, because it should be uniform.
Oh, okay.
Yeah, you're right. It should be uniform. There are some of those differences are based on like the women's facilities too.
So we can't see the screen for who is on, and I just got a note that Travis would like to.
Oh, yeah, sure.
So he wants to give you some backup, probably.
Travis, yeah.
Yeah, thanks again, Travis Denton, Director of the facilities, and I think Dr. Yu's doing a great job and speaking for us very well, and I'm here for support, but I don't want to trump what he's saying. He's saying all the right things. We've been intentional about really not encroaching on medical autonomy, and really divorcing the process of our response from a security and disciplinary standpoint from the medical necessity and medical need, because each situation is nuanced, and because somebody's diverting or somebody's possessing either more medication than they're prescribed, or for whatever reason never got on the program and they're not prescribed it, but they're getting it through that hustle, that a punitive response doesn't seem to really do anything other than create more staff work, more of a merry-go-round into a potentially segregated or consequence environment, and does nothing to really help the individuals with their substance use disorder. And it can also muddy the water for the corrections folks who really, we need to be very procedural and very operational. If we find X and X is contraband, we deal with contraband as prescribed, as directed. Where we're getting better, both with having Turning Point come into our, not only just our academy, but into our facilities, and partnering with those external stakeholders, is hearts and minds around this are starting to change. As we bring in staff from younger generations who are, I think, a little more open and maybe have seen this in their personal life with family, friends, and whatnot. Some of the stigmas are not as, speaking from somebody who's in his 50s, it's a little bit baked in. It was a coming of an awakening for me at one point, learning about this, where many of our new staff, I think, have a better understanding of the nuanced approach to substance use disorder. So we have a ways to go, and we have some process improvements that are on deck that we're still talking about at a high level. But I think if you were to talk to us again 3 or 6 months down the road, once we kind of deploy some of these changes that we're planning, we really want to get staff to understand the nature of this medication and treat this medication, especially in just that very small amount, very similar to the way it is in the community, as a tool, as a piece of medicine. Staff we've set up a system where staff has always treated it like it was plutonium or something. And then you might hear Dr. Uliger talk about it as, look, I'm more concerned about aspirin than I am about morphine from a danger standpoint.
Mortality
from a toxicity fatality standpoint. That's right. And it's somewhere in there on that continuum. We haven't really treated it that way. So our staff are doing exactly what we've asked them to do. And we're just going to start modifying what we're asking them to do in the lens that they look at this medication through, in a more health and wellness, harm reduction, and education standpoint, whilst also the benefit for the staff in some upcoming modifications to this is, you heard some talk about those med lines. Those med lines are really logistically different. The medication's the same, but if you go to Newport versus Rutland, a very large facility with 400 people, half of which at least, if not more, I imagine more, are on this program, and you try to line up 20 chairs, you can't fit 20 chairs in the hallway at Marble Valley. So so there's different approaches to get to the same end, which is to get people, and we're doing all that to stop the diversion of a relatively, and I want to be careful here, but based on my education through time and talking to folks like Dr. Uliger, no medication is probably harmless, but something that is we can approach differently and safely, and not, the juice may not be worth the squeeze when it comes to our approach to the staff hours and the resources that we spend on treating this medication as such an illicit substance. We'll still need that type of line, I think, that type of dispensing protocol for things like methadone, which are much less common. And that might be a step up for those real heavy diverters that we might, but we've got a plan, and we're moving towards really freeing up staff resources so they can really work on the work of being a corrections officer, and less of a having to do the paperwork hustle around the DRs that are generated from this, or the, kind of glorified, medication line watchers, because there's so much more to being a correctional officer. And there's a lot of other dangerous behaviors that aren't necessarily being watched while we're spending 3, 4, 5 hours in a med line. I don't know if that helped.
No, and the residents know that they've got that time available.
Oh, my goodness. We are being watched as much as we're probably being watched more than they're being watched, and they can, they clock us on all those things. So being more nimble and being on a swivel and looking at the rest of the work that our correctional officers do and freeing them up to do that work. I think that's a direct connection to staff and staffing too, because you can't develop camaraderie, you can't mentor staff, you can't do all these other things we're trying to do to raise the water in the harbor for all the boats when we're tied down to these processes that are not really giving a lot back to us. So hopefully that's a little bit of backup to help Dr. Yu here.
Well, and that's just case in point, Travis. Thank you for that, because when you have a partner like that on the security side, so yeah, have I seen people sent out of Medline because they, the security officer said, yes, I have. Has that happened less over the last year that I've been in? Yes, it has. Am I pleased that we're going in the right direction? Absolutely. And that's why. So thanks for jumping in at the right time, man.
He left.
Yeah, to jump to another meeting at 2. Well, good timing.
What I was gonna say is just really for the committee and we're missing somebody now, but is just like with inmates where, cracking the whip and saying, well, the answer is we're not giving you this at all. And we know that just doesn't work, even though in our heads, we think that we should. You also can't do that with staff, like in our heads, at least a lot of us, especially old school, country boys or military people, we're like, why? Because I told you so. It doesn't work. If you have mindsets of maybe guards who are older generations and have a mindset, you can't say you're going to do this or you're going to accept this because I told you to. You have to work with them and change their hearts and minds in order for them to have buy-in, or they might say yes to your face, but still on the ground are doing those behaviors. So it's not as simple as, in many, I know there's ideas in our head sometimes, well, we used to do it this way. Sometimes maybe it did work, but maybe not as much as people think. You just have to do things a certain way, and you have to get people to buy in because they want to buy in. You can't make them buy in.
And yes, and I think to your point, we had a great meeting a few Fridays ago now when Travis and Josh, Travis and I, and some others, Aviva was there, met with the superintendents, the assistant supers, and the some of the LUS and whatnot. And we went through some of the changes we'd like to make and why, and what we're trying to accomplish with. And people asked questions. They didn't hold back. Like, what about this and what about this? And it was really, that felt good. It was really nice to hear what their concerns are. That was where the mortality piece comes from. I don't worry a lot about aspirin, but it's easier to kill yourself with aspirin, honestly, than it is with you.
Methadone.
Yes, but methadone, yes, I worry about methadone. So nevertheless, great part.
We're gonna have to close up because we've got some other testimony, but one thing, Isaac, is there anything you can share with us on what DOC is thinking for adjusting the MOUD program?
Which would be the Dr. Yu, just broad strokes. Perhaps.
Just broad and simple. 'Cause I know you've been working on something and I just,
We're looking on bringing the Medline into the same Medline that we do.
Yeah.
We're looking at not crushing the medicine, which is a contentious point that we're working with our Department of Health, our experts at UVM, and we're about to engage the DEA on just to make sure we're doing our due diligence to keep everybody safe. We are looking at, and this is on the security side, because the rationale of not crushing the pills, if they can identify it as buprenorphine and how much it is, they can make it a minor DR instead of a major to if you have a diversion within Medline, so that there's less of a negative impact for people to dissuade them from coming.
so you want to crush them,
We want to not crush them,
not crush.
which is very progressive, but we need some input from the powers that be.
So they currently are crushed?
Mhm.
Yeah.
But then you can't identify it.
So we're gonna get into this
Yes.
pretty deeply. So I just wanted to have an oversight. Now, this is what you're working on internally with your policy?
Yes.
Or you're gonna need legislation for something that you're thinking of. So this is all internal policy.
To sum it up, because there's multiple different kind of technical changes, we're really trying to assess how we're responding to diversion, how we're administering MAT. So the medication line has been mentioned, and really assess how much energy we're putting into different components of managing the process, trying to identify ways that we can create opportunity to respond with therapeutic interventions, instead of punitive ones, and looking for ways in how we change how we administer it to destigmatize MAT further, to kind of feed into what will be, what we are hoping is a culture change around MOUD.
It's two major problems, really, trying to meet that community standard and also draw down the immense amount of work
Yeah.
on our staff when we have very few
Yeah.
staffing resources to bear right now. Trying to kind of also lessen the burden on our teams.
So if we do work on H32, how would the work we're doing on it and what H32 is attempting to do, does that have impact on what you're trying to do with policy changes? Or does policy changes impact what H32 wants to do?
H32 would have major impacts on those changes we're trying to make. We were not involved in the drafting of H32. I know we talked about that briefly yesterday. We look forward to future comment on that.
So we'll have to get into that once, if we do work on 32.
Is it not enough or too much? I know that's oversimplified.
I think we'll get into it next year.
Kevin, I want to, not enough or too much in terms of,
I don't even know what H32 is. What I'm hearing is that there's numbers of issues with H32, and I'm just trying to understand if it's too much
oh, okay.
direction or
We'll get into
not.
it.
Yeah, we'll get into that when we get testimony in the bill.
We'll get into it for sure.
Thank you very much for.
Thank you. We'll have you back.
Probably more.
Yeah,
than
next
we
time
want.
you back.
Thank you, Dr.
We'll have you back.
I understand that.
We'll have you back.
Thank you, guys.
Thank you, Doc.
Yeah.
Yeah, I think it's gonna be really important for DOC to really pay attention when our legislative counsel and Katie walks us through the bill. It's gonna be really important for folks to be here for that. So we're working on next,
It's at 1 o'clock next Tuesday. Isaac and I have already talked about it.
okay.
So could I ask one more question?
Yep.
Of the over 50% of the population that's in the med lines, roughly, how many of those 50% are there for heart or diabetes or other things other than illicit drugs?
Oh, when we mix them up, it depends on the facility. Is our sickest
Okay,
folks are
just
not every
Best guess. I understand it varies all over the place.
50/50.
50-50.
And OUD is our most common chronic disease that we treat. So
Hmm, yeah, okay. So let's switch gears. We're still dealing with corrections. But we're dealing with a new initiative that started last year with having CCV classes offered within our facilities. So we have Joyce Judy, who's president of the Community College of Vermont. And I'm assuming Brian O'Connor. I think there's 2 chairs still up there. Come on up. File in.
Thank you.
Thank you.
I will. Yeah, I got a few. I was getting some.
Yeah, if you have to take a personal break, take a personal break.
yeah, you know, I know I'm.
We're gonna take a break.
You gotta wait.
Oh, no, we got.
You gotta form. You gotta wait now.
I was gonna say, I'm not.
You can't break yet.
No,
but-
we gotta
Okay.
wait for,
I'll wait for
and I'm
someone-
next
someone
to
to come
you.
back. It's all right.
No, you're waiting.
Oh, negative.
Yeah, well, I need to think of it first.
We'll see who.
Mine's not as urgent. 'Cause I
Okay,
think-
too much information.
We're still alive, yeah.
Need too much.
Welcome, Joyce.
Thank you.
It's like school, right?
That's
Oh.
exactly right, but you know, just whatever, we're all people, and we
Yeah.
have urgent needs,
Yes,
some are less urgent.
So last year, we had you folks in talking about providing college courses to both of our inmates as well as our staff. And so we want to get an update on how that's working, and I know that there's talk of expanding it. I also know there's issues revolving around within the facilities, the Wi-Fi issue, and we really worked last year at the end of the session to see if we could get some money from the broadband group, the board, to update, install better Wi-Fi connection within our facilities, and that money was not granted. Some of us are working with the Energy and Technology Committee to really see if we can get some more support for this. the DOC is going, will be in discussing this. But I wanted you folks to come in. We have a new committee. We have 6 new members here. So if you can give us the background, how it started, where it's headed, it'd be great.
Great, and I'll give a little overview of CCV as well and all of that. So,
Good identify yourself.
oh, yes, yeah. First, I'm Joyce Judy. I'm president of the Community College of Vermont.
I'm Brian O'Connor. I'm the Director of Corrections Education for CCV.
And so, first of all, thank you, Chair Emmons, for inviting us to come back. This is a pretty exciting program. And the nice thing is, we're here not asking you for money, but we will be asking you for some help in terms of just the issue that Chair Emmons has asked. And I will say that Chair James caught me in the hall and said, you know, we'd like you to come and talk to us about that. Well, so I think that maybe the stars are going to be aligned. But I want to begin, I will give a quick overview of CCV and why we got involved in this work, but I want to just start by acknowledging Isaac and Commissioner Demel's work. This is a partnership between CCV and the Department of Corrections. And, you know, I think that, as you can imagine, marrying 2 cultures, an educational institution and a corrections institution, comes with its challenges. And, you know, we just have to work through it because, you know, what corrections mission is, you know, in terms of keeping people safe and keeping people housed and all of that. And, you know, and our mission of, you know, providing people with access to education, it's just an interesting, sometimes it's quite interesting in terms of how we work through the issues. But I just have to, I'm so grateful to Isaac and Commissioner Demel, just in terms of helping us each challenge we have work through it. So I just wanted to acknowledge that and say that. But for people who are new and haven't heard my sort of spiel, I'll just give you a quick background about CCV and then also why we started working in corrections. So first of all, CCV is one of the 2 colleges in the Vermont State College system. So Vermont State University, which is now made up of the legacy institutions of Castleton, Johnson, Linden, Vermont Tech. And so those institutions, did I leave out one? Castleton, Linden, Johnson, Vermont Tech. And so now that's Vermont State University, and CCV is the second institution in that system. CCV is a college that we have 12 locations throughout the state of Vermont, and we have a very robust online program we did prior to COVID, and it's only gotten more robust during and following COVID. CCV is also, we serve 10,000 Vermonters a year. So we are the 2nd largest institution in the state of Vermont, even though we're spread out throughout the state, and our classes are small, 10 to 20 students. We serve a lot of Vermonters. And for us, we oftentimes think of ourselves as the open end of the funnel. We really help people who oftentimes wouldn't imagine that they could access and go to college, get to go to college, get a certificate, get a degree, transfer. We have amazing transfer agreements. Our students go from CCV to Vermont State University, CCV to UVM, CCV to Norwich, Champlain, out of state. So it really provides just opportunities for students to access and get the skills they need in some ways to get the jobs that are here in Vermont. So sort of with that as a background, why did we get involved in corrections? Part of our mission is about really providing access to education for all Vermonters. And if you think about the populations that are not being served, people who are incarcerated are a population that haven't had access. Many of them have never had access to going to college. And as we thought about that population and thought about, okay, the majority of people who are incarcerated in Vermont, many of them are going to be released, and they're going to be released back into Vermont community. And as all of you know, Vermont's recidivism rate is high. You know, it's 50% or plus. And so if you think about that, you know, I often think about, okay, if I committed a crime and I went and I served and I was released and I was released right back into my community with my same friends, why am I not going to reoffend? The chances are pretty likely that it's better, it's a better chance that I am than I am not. And so, thinking about that and talking with people in corrections, if there's ways that we can run, help people think differently about who they are and give them some skills and some hope. Maybe we could reduce it, and I'm not I'm not someone who looks just through rose-colored glasses. If we could reduce it from 50 to 40, it would be huge for all of us. And so, thinking about, how do we impact that? And so in 2016, we started conversations with the Department of Corrections. And in 2017, we got a grant from the J. Warren and Lois McClure Foundation. And I will say, I think many of you know Lois McClure passed. The McClure Foundation has been an incredible partner and supporter to CCV. And they have, they joined us in this partnership with, let's just explore offering a few courses in a correctional facility and what kind of impact would it have? And so with the Department of Corrections, we decided we would offer courses at Northern Correctional Facility. And we started, and we really didn't have any idea what would be the uptake, what would be the interest, what would be. And we found a tremendous interest in it. And so 2017, spring of 2018, we ran our first class. And it quickly, we ran one, would it work? And, thinking about, okay, so there's no technology in a facility. This is now back to teaching like it was in the early 80s. No technology. You can only bring a few things into class. I mean, everything, I get that corrections has to really look at everything that goes in and comes out of a facility. But the uptick was pretty amazing. And, at the time after we offered a few courses for 2 or 3 semesters, the superintendent in Northern said to us, I want you to know this has changed the culture in this facility. People really are thinking differently. It just happened that there were a number of the leaders, the not designated leaders, but the leaders of the institution taking courses, and all of a sudden it became the thing to do. And it was seen really differently. So we were making great progress, and we were feeling good about that. And then COVID hit, and we had to push pause on COVID during COVID, and the facilities were really locked down for the right reasons, but we had to pause our program. But at the same time, there were 2 things happening at the national level that really created some opportunities. One, there was a program called Second Chance Pell that allowed institutions to apply who were working in prisons to make it so that people who are incarcerated could now apply for Pell grants. That took care of the tuition piece, because years ago in the 80s, people who were incarcerated could access Pell, and then that program stopped. And so then they decided they would start it as a pilot. So we were, because of our work and support from the McClure Foundation, we were granted a Second Chance Pell entity. And so we were granted, and we were going to start our courses using Second Chance Pell in July of 2020. So you can imagine what happened. So everything got paused. Yes.
Are those Pell Grants chime block right now?
Not today.
No.
Who knows? I mean, if you'd asked me Tuesday morning, they were lumped into all of this, but they're not. And so not today. That's my answer. So after the COVID and after as the facilities began to reopen, we also, at the same time, Senator Sanders took a real interest in this population and in this program. And he was able to get us secure a $4.5 million earmark, congressionally directed spending, to support this program. That's why we don't have to come to you for funding, because it has given us a nice runway to develop a program, which when at the end of the earmark, it will be self-sustaining, because students will be able to have Pell Pell funding, which will support us being able to go in and teach the courses and provide advising. So it's a really great program because we're able to fund it using traditional funding. So we're here, and I'm going to ask Brian to share with you the where we are in terms of funding. In terms of enrollments and in terms of data. But the thing that is very interesting about the congressionally directed spending grant that we got, because and Senator Sanders is hoping to use this as a national model, because it has actually two strands. One is to support people who are incarcerated, but the other is to support employees who are in corrections. Because one of the things that they have found in these programs throughout the country is that one of the biggest barriers to people who are incarcerated enrolling and taking advantage of any kind of coursework in prison are the people who work with them. Because I actually had a person who worked in corrections say to me, what do I have to do? Commit a crime to get my education paid for?
It's resentment.
And so now we can say, nope, because we have a program that allows, and we also got it expanded to include the families of people who are incarcerated. So the Department of Corrections, this is a great recruitment and retention tool for employees at the Department of Corrections, because now they can say, you can continue your education. And, and some people are working a lot, they don't have the time. But if you can say, and your children have access to some opportunities, it's a real, and, sometime you might ask Isaac to talk about that, but we have seen a pretty critical uptick in the number of people who staff and families who are taking advantage of that. So there were some challenges because we're right now at capacity because of limited space and staffing at the correctional facilities. And so what we're hoping is after this, we can get you to keep nudging that we really do need to wire the facilities and have be able so that people who are incarcerated have access to technology. And Brian will talk to you about that. This doesn't mean that inmates now are going to have access to the internet or, it's very controlled. Maine has done a brilliant job. Maine is actually a leader in corrections education. So I'm going to stop there, but it's a really exciting program. It's really helped us. We feel like it's part of our mission. And we have some pretty amazing success stories of people who have been incarcerated and now are out and then they took courses and now are out and employed. So I will turn it over to you,
Sure.
Brian, and you want to talk about enrollment?
Yeah, so thanks for the opportunity to come here and speak again. Just to go back to the goals of the program and the initiative that we have in the funds from Department of Justice, the goals are to reduce recidivism, strengthen the workforce, and improve the lives of Vermonters. And so a lot of the lenses that we look through are we actually achieving those things? There's 4 separate sub-programs within this, 4 subpopulations that can benefit from this. The first is the one that everybody thinks of when they hear corrections education in college. It's our incarcerated students. Right now, we have 120 individual students who are in classes in CCV in the facilities. And they're all in our professional studies program. They're receiving mentoring, tutoring, study halls, advising, and now financial aid. We actually have over 10 students who are receiving Pell Grants. So that connection has been made to that funding source for future sustainability.
And that's 13% of the incarcerated population in Vermont.
Yeah, so 13% of all of the sentenced people are now involved in CCV in some way. So that's been phenomenally successful. We're very proud of it. The second group of students we have is the staff students. So those are anybody who works at the Department of Corrections can receive 2 vouchers per semester to use for any course in any format at CCV, however they want. If they want to take stained glass because that's something that's going to increase the quality of their lives and make them enjoy their jobs and stay in their jobs more, they can do that. If they want to use that to take criminal justice classes for career development, they're empowered to do that too. So those are separate from the classes that the incarcerated students are taking. They can take whatever they want in any format. Incarcerated students, they're inside the facilities. They're taught by teachers that are only available to those. The third group, which Joyce just talked about, was the family students, which came on maybe about a year ago. And I think was one of the coolest ideas that's kind of come up since we've been running this. And not every corrections officer sees college for them, wants to progress, but a lot of them want opportunities for their families too. And that is increasing in popularity and is now almost as popular as the vouchers that we provide for staff. So it's an additional 2 per staff member that they can give to their family per semester.
I didn't want to break this up.
Okay.
Yeah.
I think there's a question here.
You know, I'll let you keep continuing. I just was curious what those numbers were for staff in the family.
Yeah, so it's about 50 per semester,
50
about
per-
35 staff, 15 family.
Oh.
Yeah,
3 semesters in a year or 4?
3. Summer, fall, and spring.
We think this is spring, but.
Well,
Yeah, in my case, yeah,
It's down 7.
yeah.
So, and then the fourth one, and this is the one where the numbers are the smallest, but it's the newest and it's the one that I'm most proud of, is our reentry vouchers. So about 2 months ago, we went to Senator Sanders' team. We said, can we offer vouchers for anybody who's releasing within a year of the end of their sentence? A lot of these students would be eligible for other types of funding, but we wanted the ability to say to somebody who's releasing, or maybe he's releasing mid-semester, and so we can't put them in a class that's in a facility because they wouldn't be able to finish it. Hey, there's CCV waiting for you out there. So we began that January 1st, and we had 2 students, and it's just 2, but that's a really big 2 as far as I'm concerned, who have released and came to CCV. And sort of a story that I just want to share was on Monday, I was in picking up some materials. We hired somebody out of the facility to do some work with us. It was actually an interview that we conducted inside Northern. The case manager arranged that I could go in and interview this person. And we hired him out of the facility and actually became full-time, fully benefited last summer, and is now a central member of our team. But I went in to pick up some supplies from him, and he was meeting with a student who had released on the 14th and was in there on the 27th in like a button-up shirt and stuff, and I'd only seen him in his corrections attire. And he was in there with his folder trying to register for classes. And it was just really cool to see that turnaround. It was like 13 days, and the first thing he did, he was incarcerated for 9 years. And the first thing he did was connect back into that community. And actually, he was incarcerated along with the person who he was meeting with, our staff person.
Wonderful.
Yeah, so I think that a lot of that's kind of the culmination of this, right? There's a period of intense vulnerability at release. And that's where people are going to be looking for community. They're going to be looking for jobs, preparedness and readiness. And anything we can do to button that up and tighten that up, I think is pretty important. So those it's the smallest group. It's only the 2, but that's the one that I'm most proud of at this point. So thanks.
So what courses do they take through CCV? What are some of those courses?
And can I, one of the things that's when Brian will describe what we're currently offering, but that's why we need technology. Because technology will give us the option to offer, like we would like to offer a lot of manufacturing courses so that, because a lot of the incarcerated population, that's their area of interest. But right now we can't because of,
Yeah. So right now we're offering courses in line with the Professional Studies Associate's degree. A lot of those courses are Intro to Business, Intro to Psychology, Word Processing, Accounting, Computer Systems. Some of those courses will be a lot easier to teach once we have the education network. But I think what is important looking forward is when we're looking at Pell Grants in the sustainable program, we want to be able to leverage those funds towards other degrees and certifications, including technician certifications and a manufacturing cert. There's a lot of employers out there who are reaching out to us and very interested in hiring from this population. And so if we can bring in this education network and make some of these connections and bring on, without getting into too much detail, there are machines that simulate these production techniques. So if we can bring those in, we can give the incarcerated students this vocational manufacturing experience.
Well, and I'm just so happy to hear that because we've talked about that for a number of years, wanting inmates to be leaving the facility with a certificate or something in hand that, they could go out and get a job and start afresh. And so thank you for doing this.
Yeah.
and we're about to, you might talk about the equipment that we're
Sure.
about to purchase, we were gonna purchase it, but then, on Tuesday, but now it's back on the floor and we think we can purchase it.
Yeah, so there's these machines that are a number of them. They're made to use a tech lab that can teach students all the different principles and activities of manufacturing. And we are working with a vendor and starting discussions with PDOC to build a tech lab for CCV for vocational and manufacturing training on modern equipment. So this isn't building street signs, and this isn't, doing coat hangers, which is common, and Maine does actually a good job of that. But this is roles in manufacturing and production that we know we have a need for in Vermont too. So hopefully we're strengthening the workforce by providing small employees.
Thanks.
So when you came in, we were talking about the MOUD program within corrections. Are you, for your students, are you coming into contact with folks who are part of the MOUD program? And how is that, if so, how's that all intertwining and playing out?
I don't, not that I know of, I don't think about that much. We kind of just interact with them as students individually from everything else. So there's no interaction that I know.
I'm just curious in terms of the reentry piece.
Yeah.
Because it's really important that they continue on some form of MOUD once they get back into the community. And I'm just wonder how that interplays with their continuing their education. Maybe the education piece is a base for them to really stay stable. But I'm just curious what the interaction is there.
Might be a conversation. Yeah, we meet regularly with Department of Corrections and we can, certainly a good question.
Will and then Kevin.
You're talking about recidivism a minute ago and just how it's very high in
Yeah.
Vermont in general. Do you have a breakdown of what it's like for people that go through CCP courses and then get out in the community versus those that don't take your courses and all that?
We don't yet, because this is so new, but that is something that we really do want to track. We've had a few success stories because, the person that we hired was incarcerated for 10 years. And he is now working for us, and he was released, I think, a year ago. And we employed him before, as he was coming out, and he is a terrific employee. So, the thing is that as they're released, we can figure this, we can follow this, but it's all really new. But that's our hope is that, again, we're not going to be successful with all, but if we can, it's almost starting out this one by one by one. If we can change this one and then we can change that one and then we can change, because the grapevine is alive and well, and just like within the facility, outside the facility is the same thing. And, we have a lot of employers who are I think of them as second chance employers who are very willing to work with us around this. They're happy to employ people who are incarcerated and give them a second chance. And so we're trying to build all those relationships as we go along.
So can I just ask, for folks that you have been working with who have been released, like particularly the person for 10 years, are they under a furlough or parole, or had they maxed out? I know it may not matter.
I don't know, but I'll ask.
Just curious.
He was fully free and clear within, I think, a month or two of his release. So he had some restrictions for the beginning, but he also was, he came with letters of recommendation from case managers and people within the facility. So I think he did pretty much everything he could with the time he was incarcerated too.
And do you know about the second?
I don't know. I haven't.
I'm just curious. I know, a lot of folks are released prior to serving the full time.
Yeah.
And they're either on furlough or parole. And I'm just wondering what you're offering, how that would help folks who are on furlough.
What's tricky is, this is just personal in my job, what's tricky is knowing how much to explore that rather than so typically it's their story, it's their narrative, and I'll engage with them and we'll engage with them however they want that to be part of their narrative continuing forward. But I think a lot of you'll see our interactivity with VDOC is sort of minding that relationship where we want to be CCV and we want to have a relationship with our students on on a school to student basis. Part of their experience is that they're incarcerated. That's a reality, but that's something that I'm often thinking about. So it's a good question.
I'm just curious in terms of trying to understand folks who are on furlough and parole.
Yeah.
If they're involved in CCV while they're out in the communities, it really is a help
Yeah.
for them in those statuses. Kevin?
Could I assume that electricians, plumbers, masons, is there any opportunity for that? That's not typically considered college course, but there's such a huge need and there's so much money that it's made.
Yeah.
And everybody isn't for college, but these other skills will be huge.
I can talk.
Yeah, go ahead.
to that. So we're college, so a lot of what we offer is college. We do have certificates too, which are the fullest degree programs, but we also do work with the education department and risk intervention services. So a lot of our relationship with them and with those students is trying to figure out what that student needs and where that sits in that education continuum. A lot of times we're a incentive for somebody who might not have a GED to go through that process. And other times they'll come explore something with us, talk to our advisors, and we say, hey, maybe you want to go back to the Department of Corrections and work with them on your education. So we don't do that, but we advise those students once they're our student towards their careers, kind of wherever that might go.
Thank you.
No, and I think that, we're in some conversations with the Department of Corrections of, how do we continue to broaden what we offer? So, I think that that's why we're so interested in the technology, because it gives us so many more options, both in terms of the content, but in terms of the numbers. Because right now, in Northern, for example, we can only offer 4 courses a semester in that facility, because that's only that in terms of space and in terms of their staffing to support. We bring faculty in, but there still has to be someone there sort of supporting that entity. So that's why if we could just expand so much more. And you're exactly right. We're limited. We're limited because we have to figure out what courses can we teach without using technology. So that even really limits, think about that in terms of, what can we, because we're awarding 3 college credits. So those students can take these courses, when they get done, they can transfer to UVM, they could transfer to Norwood. If we haven't offered them a course that truly is, got college level content in it, then we have done them a disservice. So we are very mindful of what we can and what we can't offer.
So are you in every facility?
We're in 4 of 6 right now.
So which of the 4?
We're in Northern, Chittenden, Northwest, and Southern State. The populations at Northeastern and Marble Valley, they're a lot smaller, they're a lot shorter stays, and there's not enough to sustain a full class there.
So you're in those central facilities, more like the bigger ones. And how has the response been in each of those facilities with staff? Has it been
Sure.
supportive, or is it different for each facility?
I think one of my a learning experience I had is that every one of the facilities has a little bit of a different culture. Northern, it's kind of the biggest one and has experience with our pilot program. So Northern, we run 4 classes in there. If you were to go to Northern when CCV was in session, it would look like a college. There's people coming across the yard with their binders and their books. And, our staff moved through there very easily. Chittenden about the same. That was one of the first ones we started too. Northwestern's taken a little bit more time for them to warm up to us. From what I understand, I think they've told us that their population just needs some extra concerns around it. So, but we're, doing the best we can to fit into that. And then Southern State, I'll give a shout out to Southern State. They've been very welcoming. It's pretty incredible how much hospitality we felt from them. And maybe it's because we've been in 3 already, but that Southern State's really not only made space for us, but has helped to facilitate us getting in there in a way that's really great.
So are you working directly just with the superintendents or also the volunteer coordinator?
Yes.
Or both, or?
It depends. Our relationship with each of the facilities differs. We have strong relationships with people at central office, superintendents, security supervisors, volunteer coordinators. It depends. Sometimes figuring out who the gatekeeper is at each facility is going to be a little different. And for what it's worth, they're all run a little differently too. So I think
And different populations.
for sure, absolutely.
And how is your staff that are physically going into the facility and teaching? What are you hearing from them?
They love it.
I have just, and I'll just give an overview and maybe Brian could give you a couple of examples, but so it's a very different teaching experience for our faculty, as you can imagine. They don't have access, we require our faculty to use technology in their classroom. And now we're saying to this group, no, not so much. You are not, and everything that, you don't get to take ballpoint pens in and you don't, books have a certain binder, and everything has to be planned. So we expect a lot from faculty who teach. We ask a lot and we expect a lot. But 201, I can tell you that they find it the most rewarding of a teaching experience because the residents are so grateful. Across the board, it is fascinating how grateful they thank our faculty for being there. And this is, you can ask any of our faculty, it is probably the most rewarding teaching experience they have. I will say I visited a few classes and, I visited a lot of classes in my time. And I have to tell you, it is the most powerful educational experience I had. And the first one I went to, here I am, I'm in Northern. There's 14 guys in there. And, I said to them, this is when we were giving, this is when the McClure Foundation, I said, so if I was going to go back to the McClure Foundation, what should I tell them? Why should they keep funding this? And it was just so profound what they said. And they were so honest. And what was fascinating to me is they all owned their crimes. And there were 3 people in there that had done murder. And they had I took a person's life, I understand. But they owned it and they were, okay, now how do I go from here? And they were just so grateful and things like, this is the one time in my day that I can use my brain. I can be treated, it's my colleagues. It was just really, it's what you want education to be, but they stated it in their own words. One person said to me, I have to tell you, this is the first time my family has ever been proud of me. And another one said to me, this is the first time I have had something to talk to my daughter about.
Wow.
So those are things that, we take for granted. And it was just like, and they didn't have to say that because this wasn't going to impact anything other than I was, what should I say to a philanthropist? It was just so, but.
Yeah, I would say it's a hard class to be taught. It's cinder block walls and fluorescent lights for 3 hours. It's just tough. And a lot of, I think having to be creative and think on their feet and they don't have access to the technology that they're used to. But I do think that every single person would say that the challenges and the creativity that creates has been very much worth it for them, and almost all of them come back for another one. And I think the students are highly engaged.
So for the students, can you give a broad range of ages? Is it 20, 30-year-olds or is it 20-year-olds all the way up to 60?
Yeah.
70?
Yes.
I would say, in the class that I was in, we had some, pretty young. One kid, he was in there. He shared very publicly that, he took the life of his father. And so he was in, and he was tried as an adult. So, and he'd already been in for like 10 years. He was incredibly bright. So he was young. And then I would say there was a guy in there that probably was in his 60s. And so everything in the middle, it's the same way with CCV classes. It's just, but that's what's the richness of it. And I think for some of them, they hadn't shared with each other and they hadn't known, and they developed this camaraderie. And going back to my statement earlier, some of them were sort of the leaders in the facility, and then it became cool to take courses. That is a very different thing than, so yeah, does it work perfectly every time? Of course not. But I would say as a general rule, I have yet to have a faculty member say to me, I won't go back, but instead I'm ready to sign on. And they're all people, we have to run them in person. And, you go into a facility and, you feel kind of naked when you go through those double doors and you have to leave everything behind. You know, it's just very different, but it's pretty humbling, but it's pretty powerful.
Well, I was gonna say something to that extent. We were, talking about recidivism and it can't hurt. I mean, whether or not the recidivism rates drop dramatically, they're not gonna go up.
Yeah.
The different factors that most of us already know that lead to recidivism or criminality or addiction issues and stuff. The more you can do to build somebody's mind, the better off they are, the better off society is. Could be recidivism because be the reason you're in to begin with. Like a lot of things that people do that are negative are ignorance. And the more knowledge you can give them, the more obviously fear can come from ignorance. Right? I don't know what's going to happen, or I don't know what's coming next. Or, you mentioned, first time my family's ever been proud of me. That's one of the things that can lead to one of the signs of recidivism is bad family relationships or neighborhood or the environmental factors, right? So the more you can do to build somebody's self-confidence and in turn, obviously their knowledge base, the better everybody is. So when anybody that's listening, maybe 6 people, but hopefully more, that's listening to us, that the more we do to prepare inmates or anybody really for healthy reintroduction into society, the less likely there's going to be problems down the road. In fact, the more likely there's going to be positive outcomes down the road where, as you mentioned, the gentleman for 10 years and is a great employee, that's not going to happen. But usually doesn't happen just on a whim. It happens because, yes, they made a wise decision, but also probably somebody somewhere invested in them and gave them an opportunity. So it's great that we have these programs, and we'll see where it leads, but I don't see that it can lead somewhere negative, so.
Well, I think the key is the next step was to get the Wi-Fi. That's the biggest.
That is, install this, Brian keeps telling me, Brian, go for it.
No, but yeah, it's an existential threat to the program. At some point, we have core classes that can only be done with the use of the education network. And to achieve these degrees and to actually get to the finish line for these students, they'll need.
Did you have something?
Yeah, I just wanted to interject. No, I was just curious about the rates, just to see how we could help expand it and show the need for it, because I think a lot of people are data driven that kind of teared me up when you said those stories, because.
Is this for recidivism and so yeah, the challenge with recidivism and college attainment is a lot of it is individuals who have completed a degree in a school are less likely to end back up in jail, and that number is somewhere above 70%. It's a dramatic change. I'm sure there's a lot of self-selection in there and stuff too, but those are 2 really hard numbers to get, especially in a small state like Vermont, where you have completion of a college program and 10-year recidivism rates. So we're looking at some statistics that'll be helpful in the interim. For example, does being involved in a CCB class reduce the amount of disciplinary records? And so there's some smaller indicators that we can use too to help us get at quality of life changes in the entire system, not just for this individual.
I really want to keep the conversation going in this building, trying to get the money. Do you know how much money would be required? Is it around 3 million?
Yeah, I think we did the heat mapping, and I think it's 3.5. Well, we did that a couple of years ago, just to fully outfit the facilities with Wi-Fi. I think it's probably a little higher, maybe closer to 4 now. That's.
How much were you asking for from the community broadband?
I don't know.
I don't know. Yeah, because we wrote a letter of support last year.
Because they've made some progress. We're getting closer, right?
So if there's something that we could coordinate and really kind of keep the foot on the gas on this, because I did reach out to the chair of Energy and Technology. She did come through and take some testimony. It's on their radar. Any work we can do in this committee, any work we can do in Appropriations Committee would also be helpful.
The commissioner outlined that it's a priority.
No, but we
testimony fairly recently.
But we need the money from
Yes,
the broadband group so that we don't have to use general fund. The budget. That's the key. We could get that awarded to them. Anything else? We finish up, we're on the floor, and then when we come back off the floor, we have BTS with us.
Great, and thank you. If there's more, we can help support whatever. But again, I just want to give a real shout out to corrections because they are great.
Here's was a wonderful pickup after the last testimony.
Well, I have to come in sometimes and ask committees for money, but this is the nice story because I'm not asking, we're just asking for a nudge around. Yeah,
No, trust me.
To get this done.
We can nudge.
good. Thank you.
You can do a good job.
Sure.
Yeah.